Let's start our lecture today out with acetaminophen toxicity. Every year, acetaminophen overdose accounts for approximately 500 deaths and over 500,000 emergency department visits. It is one of the most common causes of acute liver failure. Remember, acetaminophen is not just found as Tylenol. It's also included in combination narcotic medications such as Norco and Percocet. Patients often unintentionally overdose because they don't realize they're taking it from multiple sources. Mechanistically, acetaminophen works by inhibiting COX pathways in the central nervous system through a mechanism different from traditional NSAIDs. Instead of directly binding to the peripheral inflammatory site, it reduces prostaglandin production centrally, which produces its antipyretic and analgesic effects. Under normal dosing, acetaminophen is metabolized in the liver through first-order kinetics. However, in large doses, typically greater than 140 milligrams per kilogram per day, hepatic metabolism becomes overwhelmed. Toxic metabolites accumulate and can cause significant liver injury and even kidney damage. Symptoms often develop after several days. Initially, patients may present with abdominal pain, nausea, and vomiting. As liver failure progresses, they may develop jaundice and hypotension. Concurrent alcohol use significantly increases risk because it alters hepatic metabolism and can exacerbate toxicity. It may also contribute to gastrointestinal bleeding. Management is primarily supportive in the pre-hospital setting. Provide IV fluids for hypotension and dehydration, administer antiemetics for nausea and vomiting. If ingestion occurred within 1 hour, activated charcoal may be appropriate. Charcoal works by binding the chemical in the gastrointestinal tract and preventing further absorption. The typical dose of activated charcoal is 1 gram per kilogram. Early recognition and rapid intervention are critical because once hepatic injury progresses, outcomes can become severe very quickly. Now let's shift over into antidepressants because these medications are frequently encountered in both therapeutic use and overdose scenarios. There are 4 major classes you need to understand. First, monoamine oxidase inhibitors, or MAOIs. These medications work by inhibiting the enzyme monoamine oxidase, which normally breaks down neurotransmitters like serotonin, norepinephrine, and dopamine in the central nervous system. By blocking that enzyme, neurotransmitter levels increase. Second, selective serotonin reuptake inhibitors, or SSRIs. These are some of the most commonly prescribed antidepressants today. They work by selectively blocking the reuptake of serotonin in the synaptic cleft, increasing serotonin availability. Third, tricyclic antidepressants, or TCAs. These are older medications that affect multiple neurotransmitter systems. They block reuptake of norepinephrine and serotonin, but also have significant sodium channel blocking and anticholinergic effects, which makes them particularly dangerous in overdose. And finally, serotonin and norepinephrine reuptake inhibitors, or SNRIs. These medications increase both serotonin and norepinephrine by blocking their reuptake. As we move forward, we'll break these classes down further, especially focusing on their toxicity patterns and what that means for you in the field. MAOIs are considered second or third line treatments for mental health conditions. They are usually prescribed after other antidepressants have failed because of their safety profile and significant interactions with both foods and medications. Mechanistically, MAOIs block the monoamine oxidase enzyme. This enzyme normally breaks down key neurotransmitters, including epinephrine, norepinephrine, serotonin, and dopamine. When the enzyme is inhibited, levels of these neurotransmitters increase and continue exerting their effects. 2 classic examples are phenylazine and phenylclopramine. These are considered more dangerous because they are non-selective and irreversible inhibitors of monoamine oxidase. That means that they block multiple monoamines and the body must synthesize new enzymes to restore function. The major concern with MAOIs is interaction. Combining an MAOI with an SSRI or other drugs that affect monoamine metabolism can lead to serotonin syndrome, which can be a life-threatening complication. Dietary interactions are also critical. Foods high in thiamine, such as aged cheese, aged meat, beer, wine, yeast products, and even avocados, can trigger severe hypertensive reactions. Pyramine itself acts as a monoamine and, when not broken down properly, can lead to excessive sympathetic stimulation. Fortunately, overdoses are less common today because MAOIs are prescribed less frequently. However, when they are involved, especially in combination with other serotonergic drugs, the consequences can be severe. Understanding the mechanism helps you anticipate the toxicity pattern. When MAOI toxicity occurs, the presentation is driven by sympathetic overactivity. You'll often see agitation, tachycardia, vomiting, and significant blood pressure changes, either hypotension or hypertension. Patients may complain of palpitations, develop dysrhythmias, experience seizures, and spike high fevers. As toxicity worsens, serious complications can develop, including coma, CNS depression, shock, and muscle rigidity. The underlying problem is excessive circulating monoamines, epinephrine, norepinephrine, serotonin, and dopamine, leading to an overstimulated sympathetic nervous system. Treatment is largely supportive. Benzodiazepines are your first line therapy to control agitation and seizures. If the patient is hyperthermic, initiate active cooling measures early. If the patient becomes severely hypertensive, labetalol may be considered, but this is typically reserved for severe cases and is often not necessary. Contact medical control before initiating antihypertensive therapy. For, for hypertensive patients, elevate the head of the bed to about 30 degrees to help reduce intracranial and vascular stress. The key takeaway here is sedation, cooling, and supportive care for MAOI toxicity. Selective serotonin reuptake inhibitors, or SSRIs, are among the most commonly prescribed antidepressants and are used to treat a wide range of disorders, including depression, generalized anxiety, OCD, panic disorder, and certain eating disorders. They work by inhibiting the reuptake of serotonin at the presynaptic neuron, allowing more serotonin to remain available in the synaptic cleft and enhancing its overall activity. Because they increase serotonin levels gradually, the onset of therapeutic effect typically takes 2 to 4 weeks, and that's an important consideration. SSRIs are generally associated with fewer side effects and a safer profile compared to older antidepressants because they have minimal adrenergic and anticholinergic effects. This makes them less cardiotoxic than tricyclic antidepressants. However, toxicity can still occur in large overdoses. Cardiac effects, particularly QT prolongation, have been reported, most notably with citalopram and escitalopram. At high serum levels, SSRIs can affect ion movement across cardiac cells and other conduction. At high serum levels, SSRIs can affect ion movement across cardiac cells and alter conduction. Common medications in this class would include Lexapro, Celexa, Prozac, Zoloft, and Paxil. Lexapro and Celexa are associated with an increased risk of cardiotoxicity due to QT interval prolongation, which in severe cases can progress to Torsades de pointes. A major complication of SSRI toxicity is serotonin syndrome, a condition caused by excessive serotonin activity in the central nervous system. Clinical features would include mental status changes, agitation, hypertension, hyperreflexia, nausea and vomiting, and dystonias, which are involuntary muscle contractions. Serotonin syndrome can occur with SSRI overdose or when SSRIs are combined with other medications or substances that increase serotonin levels. Patients should also be cautioned against using supplements such as St. John's wort while taking SSRIs or MAOIs, as this combination can significantly increase the risk of serotonin toxicity. Management is primarily supportive. Ensure airway protection and provide advanced airway management if needed. Administer IV fluids to support perfusion and correct dehydration. Initiate active temperature control measures in patients who are hyperthermic. Benzodiazepines are the treatment of choice for seizures and significant agitation. Tricyclic antidepressants, or TCAs, work by inhibiting the reuptake of two major neurotransmitters, serotonin and norepinephrine. By blocking reuptake, these neurotransmitters stay in the synaptic cleft longer, which produces the antidepressant effect. However, TCAs don't just affect serotonin and norepinephrine, they also antagonize cholinergic, muscarinic, histamine, and alpha 1 adrenergic receptors. And this is where many of their side effects come from. From a cholinergic or anticholinergic standpoint, you'll see blurred vision, constipation, urinary retention, and tachycardia. From a histamine receptor blockade standpoint, patients may experience sedation, confusion, and weight gain. Alpha 1 adrenergic blockade can cause hypotension and reflex tachycardia. One of the most important points for us in EMS is that TCAs have a narrow therapeutic index. That means there's a small margin between a therapeutic dose and a toxic dose. Because of their multiple receptor effects, toxicity can present in many different ways. Critically, TCAs also block fast sodium channels in cardiac tissue. This sodium channel blockade can lead to QRS widening and dangerous arrhythmias, which is why TCA overdoses are particularly concerning from a cardiac standpoint. Now let's talk about TCA toxicity. Clinically, these patients often present with tachycardia, hypertension, dilated pupils, agitation, hallucinations, altered mental status, seizures, and in the most severe cases, coma. You're essentially seeing a mix of anticholinergic toxicity and cardiac instability. The most frequent cause of death from a TCA overdose is either profound hypotension or lethal heart arrhythmias. That's what ultimately kills these patients. One of the most critical mechanisms to understand is that TCA's blockage of fast sodium channels in cardiac myocytes. Specifically, they block sodium channels during phase 0 of the cardiac action potential. This slows depolarization and results in QRS widening on the EKG. When you see a widened QRS in a suspected TCA overdose, that is a red flag. A QRS greater than 100 milliseconds is associated with about a 34% chance of leading to a seizure. As QRS duration increases, the risk increases. If untreated, this sodium channel blockade can progress to ventricular tachycardia or even torsades de pointes. So, from an EMS perspective, any suspected TCA overdose should immediately trigger cardiac monitoring and close attention to QRS duration. When managing toxicity, sodium bicarbonate is indicated for a widened QRS complex. It is also indicated in metabolic acidosis, hyperkalemia, cardiac arrest with renal failure, and certain other overdoses such as salicylates overdose from aspirin. Sodium bicarbonate acts as an alkalinizing agent that counteracts acidosis. The initial adult dose of sodium bicarb is 50 milliequivalents IV or IO bolus. In pediatric patients, we would give 1 milliequivalent per kilogram IV or IO to a maximum dose of 50 milliequivalents. Use caution in patients with CHF and renal failure because of the sodium load in the medication. If the patient develops torsades de pointes, treat with magnesium sulfate. Provide IV fluids as part of supportive care, monitor closely for seizures, and treat them with benzodiazepines if they occur. For hypotension, norepinephrine is the preferred vasopressor, though phenylephrine may also be used when appropriate. Now let's shift into central nervous system depressants. The major categories you need to think about include alcohol or ETOH, heroin, and other narcotics and opioids. Also include benzodiazepines. All of these substances depress central nervous system activity to varying degrees. While their mechanisms differ, the common theme is decreased neurologic function, which can range from mild sedation to respiratory depression and coma. As paramedics, recognizing these classes quickly is critical because they all carry the risk of airway compromise and hypoventilation. A benzodiazepine overdose There are over 50 different benzodiazepine agents marketed worldwide. So this is a very common class of medications. True isolated benzodiazepine overdoses typically don't happen, but more often they occur in combination with other drugs, especially opioids or alcohol, which significantly increases the risk of respiratory depression. Mechanistically, benzodiazepines potentiate the inhibitory effects of GABA by increasing the affinity of the GABA A receptor for the neurotransmitter GABA. In simple terms, they enhance GABA's calming effect on the brain, which leads to sedation, decreased level of consciousness, and central nervous system depression. So, what symptoms would you expect in a benzodiazepine overdose? Typically, you'll see drowsiness, slurred speech, ataxia, altered mental status, and in the most severe cases, respiratory depression, especially if combined with other central nervous system depressants. Management is management is primarily supportive. First, maintain the airway, provide oxygen as needed, and be prepared to assist ventilations if respiratory effort declines. If the patient is hypotensive, administer IV fluids. Bromazicon or flumanazole is the reversal agent, but it must be used cautiously because it can precipitate seizures, particularly in chronic benzodiazepine users or mixed overdoses. So let's talk about Ramazicon or flumanazole. This is a benzodiazepine receptor antagonist. It works by blocking the actions of benzodiazepines in the central nervous system, essentially reversing their sedative effects. It's indicated for respiratory depression that is clearly secondary to benzodiazepine overdose. However, this is where we have to be very cautious. It is contraindicated in seizure-prone patients because it lowers the seizure threshold and renders benzodiazepines ineffective. So if a seizure occurs, your benzo treatment won't work as expected. It can also precipitate acute withdrawal symptoms in patients who are chronically dependent on benzodiazepines, which can be dangerous. Because of these risks, the main use of Ramazicon is typically in non-addicted patients, such as a pediatric patient with an accidental benzodiazepine ingestion, where the risk of withdrawal or seizures is much lower. When we talk about narcotics like heroin and methadone, it's important to understand the terminology first. Opiates are derived directly from the opium poppy, while opioids are synthetically made. Heroin is a common opiate and can be injected IV, snorted, or smoked. It's highly lipid soluble, meaning it crosses the blood brain barrier quickly, which explains its rapid onset. Fentanyl is an emerging opioid that is now commonly abused, and one of the dangers is that the concentration of the drug can vary widely from dose to dose, making overdose much more likely. We would call that clandestine fentanyl. Mechanistically, opioid medications primarily act on the mu receptor. The mu receptor is responsible for analgesia, respiratory depression, and euphoria. That respiratory depression is what kills patients in an overdose. The kappa receptor, on the other hand, contributes to meiosis and dysphoria, meiosis being pupil constriction. Methadone is unique because it is a mu receptor agonist, but also an NMDA antagonist. That NMDA antagonism helps deter euphoria and assist in managing withdrawal symptoms, which is why methadone is used in opioid dependence treatment. So, what's your treatment for an overdose? First and foremost, airway management. That's priority number one. These patients die from hypoventilation and hypoxia. Naloxone or Narcan is administered to restore respirations and not to restore consciousness. The goal is adequate breathing, not necessarily a fully awake patient. The typical dose is 0.4 to 2 milligrams IV, IO, or intranasally, titrated to respiratory effort. Amphetamines and cocaine stimulate the sympathetic nervous system. And that's the foundation for understanding both their therapeutic effects and their toxicity. When someone has amphetamine toxicity, you'll see signs of sympathetic overdrive, tachycardia, hypertension, agitation, seizures, and in severe cases, stroke, acute coronary syndrome, and even death. The excessive catecholamine release can also lead to cardiac dysrhythmias and myocardial ischemia. Amphetamines can be a cause of excited delirium. These patients often present with extreme agitation and seemingly increased strength. If not treated appropriately, this can progress to fatal autonomic dysfunction. As the body becomes overwhelmed, you may see metabolic acidosis and hyperthermia develop. Importantly, just prior to cardiac arrest, the patient may actually become respiratory depressed, hypotensive, and drowsy. So don't be falsely reassured if they suddenly calm down. That can be a pre arrest state. Remember, medications like Adderall containing amphetamine and dextroamphetamine. Also, remember that medications such as Adderall contain amphetamines. So, even prescription stimulants can produce these effects if misused or taken in excessive amounts. When managing a severely agitated patient, the first priority is always safety yours, your partner's, bystanders, and the patient's. Before anything else, make sure the scene is secure and that you have adequate resources if needed. Once safety is addressed, attempt to verbally calm the patient. De escalation should always be your first step if it's feasible. At the same time, maintain airway and breathing. Even in highly agitated patients, you must be thinking ahead about oxygenation and ventilation, especially if sedation becomes necessary. For pharmacological management, benzodiazepines and Haldol are commonly used options for agitation. In certain situations, ketamine can be used for sedation. The decision to administer a sedative should be based on a BARS score, following your local protocol. Specifically, reference protocol UP 18 and 19. Ketamine is indicated for patients with a BARS score of 7, meaning they are severely agitated and violent. Always use objective scoring to guide your decision making rather than relying solely on subjective impressions. Much of what we've talked about up to this point can be found in our toxic ingestion protocol. It gives us a structured approach to overdose and toxic ingestion in the pre-hospital setting. The first priorities are airway, breathing, and circulation, followed by identifying the substance, the amount taken, any co-ingestions, and most importantly, the time of ingestion. If the ingestion occurred within 1 hour, activated charcoal may be considered, but only in select cases and ideally after consulting medical control. Since routine use is not recommended, the protocol then guides treatment based on the substance involved. For example, beta blocker and calcium channel blocker overdoses may require glucagon or calcium. Bicyclic antidepressant toxicity with a wide QRS requires sodium bicarbonate. And cyanide or nerve agent exposures direct you to separate toxin protocols. Supportive care remains the foundation. Fluids for hypotension, airway management as needed, seizure control, and continuous monitoring with reassessment. This protocol emphasizes recognizing toxidromes, bringing medications or evidence from the scene, and early communication with the receiving facility. Overall, this guideline helps us rapidly identify the likely toxin, intervene appropriately, and focus on supportive care while preventing deterioration. When we're managing a behavioral agitation, the first step is to use the Behavioral Activity Rating Scale or a BAR score to guide our approach. If the patient scores 1 to 4, no sedation is required, and we move on to the age appropriate protocol. A score of 5 means the patient is agitated but still redirectable. So we start with verbal de escalation and consider PO or ODT medications like allopurinol, droperidol, or lorazepam. If the patient progresses to a bar score of 6, meaning agitated and disruptive, but not violent, we continue verbal de escalation, establish IV or IO access if indicated, and escalate our medications. Options include Haldol, IM, Versed, with repeat dosing as needed within our maximum limits per protocols. We consider physical restraints following our protocol if necessary. If the patient reaches a bar score of 7, meaning agitated and violent, we transition to the hyperactive delirium with severe agitation protocol. Scene safety is the priority. Call for additional resources or withdrawal if unsafe. This level, ketamine 4 milligrams per kilogram IM up to 400 milligrams, is indicated for rapid sedation in adults, with pediatric dosing adjusted appropriately. Versed is an alternate. We establish IV or IO access, preferably with two large bore IVs, begin fluid resuscitation with normal saline, monitor cardiac rhythm, treat hyperthermia if present, and notify the receiving facility or contact medical control. It's important to remember that hyperactive delirium is a true medical emergency characterized by delirium, psychomotor agitation, hyperthermia, increased strength, and potential for sudden deterioration. These patients are at high risk for metabolic acidosis, respiratory compromise, and cardiac arrest. Physical restraints are not contraindicated but must be used cautiously, avoiding prone positioning and minimizing prolonged struggling. Sedation decisions should be based on clinical judgment and the BARS score, not outside pressure, and always with the goal of protecting the patient, the crew, and bystanders while maintaining airway and physiologic stability. Sedative medications. When we talk about sedative medications in the pre-hospital setting, there are a few key agents you need to understand. Benzodiazepines are commonly used, and in addition to providing sedation, they also act as anticonvulsants, making them especially useful in patients who are agitated and at risk for seizures. Alperidol, or Haldol, is an antipsychotic that helps control agitation and psychosis, particularly in patients who are disruptive but not necessarily experience severe hyperactive delirium. Ketamine is a powerful dissociative sedative that provides rapid control of severe agitation, especially in violent or excited delirium patients, while generally preserving airway reflexes. Droperidol is another antipsychotic that can be used for agitation and has a relatively fast onset, making it effective for behavioral emergencies. Each of these medications has a role, and selection depends on the patient's presentation, severity of agitation, and overall clinical picture. Benzodiazepines are the most common medication used in the United States to stop active seizure activity. They work in the central nervous system by binding to benzodiazepine receptors and enhancing the effects of GABA, which is our primary inhibitory neurotransmitter. When benzodiazepines are present, they increase the frequency of GABA receptor channel opening. This leads to hyperpolarization of the neuron. Think about the cardiac action potential. When a cell becomes hyperpolarized, it is harder to reach threshold and fire. The same concept applies here. Hyperpolarization decreases the likelihood of an action potential, which reduces in neuronal firing in the central nervous system. The result is central nervous system depression and sedation. In short, benzodiazepines amplify the inhibitory effects of GABA in the brain. In the pre-hospital setting, benzodiazepines have several uses, including seizure control, sedation, and management of agitation. Common examples you'll use are Ativan, diazepam, and midazolam. When administering benzodiazepines, you must closely monitor for respiratory depression and hypotension, as these medications suppress central nervous system activity. Also, remember that benzodiazepines with a higher GABA receptor binding affinity are more likely to cause retrograde amnesia, which is clinically relevant when using them for procedural sedation. Midazolam, also known as Versed, is a short-acting benzodiazepine that we use frequently in the pre-hospital setting. When it's given IV, it has a rapid onset of about 3 to 5 minutes, while intramuscular injection takes a bit longer, around 15 minutes. Its duration of action is typically 30 to 60 minutes, which makes it very useful for short procedures and acute management situations. However, there are important contraindications to remember, including hypotension, shock, and pregnancy, as it's classified as a Class D medication. Dosing for adults is generally 2 to 2.5 milligrams IV, IO, or IM, and 10 milligrams IM, with a maximum adult dose of 10 milligrams. For patients older than 65, you should cut the dose in half when using it for behavioral sedation. Pediatric dosing is weight-based, 0.1 to 0.2 milligrams per kilogram. As with all benzodiazepines, closely monitor for side effects, such as respiratory depression, hypotension, and nausea and vomiting. Because of its rapid onset and short duration, midazolam is often the preferred benzodiazepine for procedural sedation, including cardioversion and pacing. Lorazepam, also known as Ativan, is a fast-acting benzodiazepine that we commonly use in the pre-hospital setting, especially for seizure management and significant agitation. When given IV, you can expect an onset with about 1 to 5 minutes, which makes it very effective when you need rapid control of symptoms. For adult dosing, the typical dose is 2 to 4 milligrams given IV or IO as a slow push over 1 to 2 minutes. It's important that this medication is pushed slowly. If needed, you can repeat the dose in 15 to 20 minutes with a maximum total dose of 8 milligrams. In pediatric patients, the dose is weight based at 0.05 to zero point 0.1 milligrams given slow IV or IO push with a maximum of zero point 0.2 milligrams per kilogram. Now let's review contraindications. Lorazepam should not be used in patients with known hypersensitivity to benzodiazepines. Use caution or avoid it in patients with COPD, shock, or acute glaucoma. Also remember that lorazepam is a Class D medication in pregnancy. One key safety point. Rapid administration of benzodiazepines is more likely to cause hypotension and respiratory depression. That's why slow, controlled administration is critical. Always be prepared to manage the airway and support ventilation when administering this type of medication. Diazepam is a long-acting benzodiazepine with effects that can last up to about 2 hours. Like other medications in this class, it works as a central nervous system depressant and is commonly used for seizure control, sedation, and muscle relaxation. For adult dosing, you'll start with a loading dose of 2 to 5 milligrams given IV or IO. After that, you can give an additional 2 milligrams every 3 to 5 minutes as needed, up to a maximum total dose of 10 milligrams. Diazepam can also be administered rectally at a dose of 10 milligrams, which is particularly useful when IV access is not available. In pediatric patients, the IV or IO dose is zero point 0.1 to zero point 0.3 milligrams per kilogram, with a maximum of 4 milligrams. If given rectally, the pediatric dose is zero point 0.5 milligrams per kilogram, with a maximum of 10 milligrams. Let's review contraindications. Diazepam should not be used in patients with respiratory depression, shock, asthenia gravis, or liver impairment. It's also classified as a Class D medication in pregnancy. One important administration point. Diazepam is not given intramuscularly, as absorption is unreliable. As with all benzodiazepines, closely monitor the airway, breathing, and blood pressure, and be prepared to intervene if respiratory depression occurs. Let's take a look at some of the other anticonvulsant medications that we might encounter. These medications are typically prescribed by a patient's primary care provider or neurologist and are regulated at home as part of long-term seizure management. One of the most important things to understand about these medications is that consistency matters. These drugs require routine, scheduled dosing to maintain therapeutic levels in the bloodstream. If patients miss doses or are non-compliant, their seizure threshold can drop, increasing the risk of breakthrough seizures. Some common examples would include Dilantin, Keppra, Tegretol as options to manage long-term seizures. Luminol, which is phenobarbital, is a barbiturate and is typically used as a second-line agent. Depakote or valproic acid is another medication frequently used in seizure disorders. You may encounter Diastat, which is rectal diazepam. This is often prescribed for home use, especially in pediatric patients, so caregivers can administer it during prolonged seizures before EMS arrival. As paramedics, it's important to recognize these medications, understand their purpose in maintaining seizure control, and assess compliance when evaluating a patient with a seizure history. Let's take a look at Haldol. This medication is commonly used in the pre-hospital setting for acute psychotic episodes, significant agitation, and schizophrenia. When you are dealing with a patient who is severely agitated or experiencing psychosis, Haldol can be an effective option for behavioral control. Haldol works by blocking dopamine type 2 receptors in the central nervous system. By reducing dopamine activity, it decreases nerve impulse transmission, which produces sedation and helps calm the patient. In addition to dopamine blockade, Haldol also has adrenergic, cholinergic, and histaminergic receptor antagonism effects. While these additional receptors effects contribute to sedation, they are also associated with many of the medication's adverse reactions. For dosing, patients older than 12 years typically receive 2 to 5 milligrams intramuscularly. For patients older than 65, a lower dose of 2.5 milligrams IM is recommended. The dose may be repeated every 5 minutes as needed, up to a maximum of 10 milligrams IM. According to North Carolina protocol, Haldol is not given intravenously. You can expect an onset of action of about 20 minutes. This is not an immediate medication. Plan accordingly and continue to manage scene safety and patient monitoring while waiting for the medication to take effect. As always, closely monitor the patient after administration and be aware of potential adverse reactions related to its multiple receptor effects. So let's review contraindications and adverse effects of Haldol. Haldol should be avoided in patients with severe liver disease or significant cardiac disease. It is also contraindicated in patients with dementia, pregnancy, central nervous system, depression, and Parkinson's disease. Because Haldol blocks dopamine receptors, it can significantly worsen symptoms in patients with Parkinson's. One of the most important adverse effects categories to understand with Haldol is extrapyramidal reactions. These are movement disorders caused by dopamine blockade in the central nervous system. Akathisia is one example and presents as an inability to sit still. This patient may appear increasingly agitated or restless, which can sometimes be mistaken for worsening behavioral issues. Dystonia is another extrapyramidal reaction and involves uncontrollable muscle contractions. You may see abnormal posturing, neck twisting, jaw tightening, or even airway involvement in severe cases. A rare but life-threatening complication is neuroleptic malignant syndrome. This presents with fever, confusion, rigid muscles, and tachycardia. This is a medical emergency and requires rapid recognition. Tardive dyskinesia is another possible adverse effect and involves uncontrollable jerking movements of the face and body. While more common with long-term use, it is important to recognize. If you encounter extrapyramidal or dystonic reactions in the field, treatment is diphenhydramine or Benadryl, 50 milligrams for adults. Prompt recognition and treatment can quickly reverse many of these symptoms. Also, monitor closely after administration and reassess frequently. One additional safety consideration with Haldol involves its cardiac effects. If Haldol is given intravenously or if recommended dosing limits are exceeded, the risk of serious cardiac complications increase significantly. The primary concern is QT interval prolongation. Prolongation of the QT interval can predispose the patient to dangerous ventricular arrhythmias. If not recognized and treated, this can deteriorate into ventricular fibrillation and result in cardiac death. This is one of the reasons many protocols, including North Carolina protocols, avoid IV administration and emphasize strict adherence to maximum dosing guidelines. Whenever administering Haldol, especially in higher risk patients, consider cardiac history, monitor the patient closely, and be alert for any signs of rhythm instability. Droperidol is a sedative, antipsychotic, and antiemetic medication. Like Haldol, it works primarily as a dopamine antagonist. By blocking dopamine receptors, it produces sedation and helps control agitation. In addition, it has antihistamine and anticonvulsive properties, which contribute to its overall calming effects. The adult dose is 2.5 milligrams given IV, IO, or IM. If needed, it can be repeated at 1.25 milligrams, but only if the benefits outweigh the risk. In pediatric patients between the ages of 1 and 12, the dose is 0.03 to 0.07 milligrams per kilogram, administered over 2 minutes. Droperidol is also associated with QT interval prolongation, so cardiac monitoring is important. A 12-lead EKG should be obtained prior to administration whenever possible. This medication has a similar mechanism of action to Haldol, so many of the same precautions apply. It's commonly used in the hospital setting to treat post-operative nausea. One critical safety point, droperidol carries a black box warning due to the risk of QT prolongation and torsades de pointes. Because of this, careful patient selection, dose control, and cardiac monitoring are essential when using this medication. Moving on to ketamine. So ketamine is commonly used in the pre-hospital setting for severe agitation and dangerously combative patients, particularly those with a bar score of 7. It is also indicated in cases of suspected excited delirium where rapid chemical sedation may be necessary to protect the patient and providers. For intramuscular administration in dangerously combative patients, the dose is 4 milligrams per kilogram with a maximum dose of 400 milligrams. This reflects the updated state protocol, which now specifies 4 milligrams per kilogram with a max of 400 milligrams. For IV or IO administration, the dose is typically 1 to 2 milligrams per kilogram for drug-assisted airway intervention and 1.5 to 2 milligrams per kilogram for post-intubation management and sedation. Because ketamine can significantly affect airway reflexes and respiratory drive, you must always be prepared to manage the airway, have suction, oxygen, and advanced airway equipment ready prior to administration. An important protocol consideration: you must obtain direct online medical control from the system medical director before administering ketamine to a patient under 15 years old or weighing less than 49 kilograms. Ketamine is a powerful and effective tool, but it requires careful patient selection, dose accuracy, and close monitoring. The last part of our lesson, we're going to cover some of the toxidromes that as paramedics we should be aware of. First, I have beta blockers. Beta blockers are commonly used in the treatment of hypertension, heart failure, tachycardias, and angina. They're widely prescribed and have been shown to decrease mortality in patients with heart disease, which is one reason they're such a foundational class of cardiovascular medications. Overdose with beta blockers can be accidental, especially since many patients take them daily. Interestingly, women are statistically more likely to overdose on beta blockers at about a 3-to-1 ratio. Mechanistically, beta blockers work by blocking the effects of epinephrine at beta receptors located in the heart and lungs. By preventing epinephrine from stimulating these receptors, they reduce heart rate, contractility, and overall cardiac workload. There are two major categories to understand. Non-selective beta blockers bind to both beta 1 and beta 2 receptors. Examples would include propranolol and labetalol. Because they affect beta 2 receptors in the lungs, they can potentially worsen bronchospasm in susceptible patients. Selective beta blockers are primarily bind to beta 1 receptors in the heart. Examples include atenolol and metoprolol. These are generally preferred in patients with reactive airway disease. Sotalol is a unique medication in that it's a beta blocker but also has potassium channel blocking activity and functions as a class 3 antiarrhythmic. At the cellular level, beta blockade reduces intracellular cyclic adenosine monophosphate, or CAMP for short. This reduction in CAMP is what ultimately produces the cardiovascular and metabolic effects we see clinically, including decreased heart rate and decreased myocardial oxygen demand. Understanding both the receptor activity and the physiologic effects will help you anticipate both therapeutic benefits and potential complications. The first clues to a beta blocker toxicity are often bradycardia, hypotension, hypoglycemia, and altered mental status. If you see that constellation of symptoms in a patient who is prescribed beta blockers, you should immediately consider overdose or toxicity in your differential. Initial management always starts with airway and breathing. Ensure the airway is protected and provide ventilatory support as needed. If bronchospasm is present, administer oxygen and albuterol. Remember, especially with non-selective beta blockers, beta 2 blockade can worsen bronchoconstriction. If the patient is actively seizing, treat with benzodiazepines. On the ECG, you may see QRS widening, prolonged QT intervals, bradycardia, or various degrees of heart blocks. These patients can deteriorate quickly. Transcutaneous pacing may be necessary, and atropine is often ineffective in severe beta blocker toxicity. so don't rely on it as your primary intervention. For hypotension, initiate vasopressors. Epinephrine and norepinephrine and dopamine are appropriate options depending on protocol and patient presentation. Another key therapy is glucagon. Glucagon works independently of beta receptors and can increase heart rate and contractility even when beta receptors are blocked. So let's talk more about glucagon. Glucagon works by increasing cyclic adenosine monophosphate, or CAMP, inside of cardiac cells. By increasing CAMP, it produces positive inotropic and chronotropic effects. In other words, it increases contractility and increases heart rate. That's a key thing to remember here, that ino refers to contractility, chrono refers to heart rate, and dromo refers to the rate of conduction through the AV node. Because glucagon works independently of beta receptors, it is especially useful in beta blocker and calcium channel blocker overdoses. Even when those receptors are blocked, glucagon can still stimulate the heart through a different pathway and improve cardiac output. Glucagon is also used for hypoglycemia. It raises blood sugar by stimulating the breakdown of glycogen into glucose and promoting gluconeogenesis in the liver. For beta blocker or calcium channel blocker overdose in adult patients, administer 2 to 4 milligrams IV, IO, or IM according to protocol. In pediatric patients, the dose is 0.1 milligrams per kilogram, IM. Glucagon can be a critical medication in toxicological emergencies, especially when standard therapies are not effective. Organophosphates. Let's move on to organophosphates. These cause overstimulation of the parasympathetic nervous system by increasing levels of acetylcholine in the body. This results in excessive activation of cholinergic receptors and produces a very recognizable clinical picture. These substances are commonly found in pesticides, herbicides, and nerve agents, such as sarin gas. Exposure can occur in an agricultural setting, industrial accidents, or intentional toxic exposures. Clinically, we divide the symptoms into muscarinic and nicotinic effects. The muscarinic effects would include excessive diaphoresis, bradycardia, bronchorrhea, and bronchospasm. These patients are often drenched in secretions and struggling to breathe. Nicotinic effects involve the neuromuscular junction and would include fasciculations, myoclonic jerking, and eventually flaccid paralysis. As the toxicity worsens, patients may develop seizures, coma, and ultimately respiratory failure. Respiratory failure is the leading cause of death in this group of patients, often due to a combination of bronchospasm, bronchorrhea, and paralysis of the respiratory muscles. To help remember the muscarinic symptoms, use the mnemonic sludgem or dumbbells. Please look that up in your textbook so you're familiar with those symptoms and presentations. It's important to understand that organophosphates can be absorbed through multiple routes, including inhalation, ingestion, and skin contact. Many of these compounds are highly lipophilic, meaning they have a large volume of distribution because they are stored in fatty tissue. They can persist in the body and cause prolonged symptoms. Obese patients may require prolonged ventilation and longer hospital stays due to this increased volume of distribution. Early recognition and aggressive airway management are critical in these patients. Now let's move into the treatment for an organophosphate poisoning. First and foremost, PPE and scene safety come first. These substances can contaminate the environment, and you do not want to become a secondary victim. Always ensure proper protective equipment before making patient contact. Decontamination is critical. Organophosphates can be present in the patient's saliva and bodily fluids, so exposure risk remains even after the initial incident. Remove and discard contaminated clothing and follow decontamination protocols to reduce ongoing absorption and secondary exposure. So let's talk about some of these medications. The first line medication for an organophosphate poisoning is atropine. Now, atropine competes with acetylcholine at muscarinic receptors. The goal is not to normalize the heart rate. The goal is to dry up secretions and improve respirations. These patients often require large amounts of atropine. Dosing is typically 2 to 4 milligrams every 3 to 5 minutes, repeated as needed until secretions are controlled and ventilations improve. Next is TUPAM, which works by reactivating acetylcholine esterase and helps reverse the nicotinic or neuromuscular effects. In adults, the dose is 600 milligrams IV, IO, or IM, according to protocol. If the patient is seizing, administer benzodiazepines as needed. One important airway consideration: avoid succinylcholine because acetylcholine esterase is inhibited in organophosphate poisoning. Succinylcholine cannot be properly metabolized and can result in prolonged paralysis. So acetylcholine esterase, that is the chemical within your body that's responsible for metabolizing succinylcholine when it's bound in the neuromuscular junction. Aggressive airway management, early antidote administration, and continuous reassessment are the keys to improving outcomes for organophosphate overdose patients. On the opposite side of the spectrum is an anticholinergic toxidrome. So this toxicity occurs due to antagonism of acetylcholine. In simple terms, acetylcholine is blocked at muscarinic binding sites in smooth muscle, salivary glands, and the central nervous system. When acetylcholine can't bind, the parasympathetic system is essentially shut down. You'll find anticholinergic effects in many common medications and even certain plants. Common sources would include antidepressants, antihistamines like Benadryl, and antipsychotic drugs. One classic plant exposure is Jimson weed. Among medications, antihistamines are one of the most common causes of anticholinergic toxicity. Clinically, there's a classic mnemonic to remember this presentation: red as a beet for skin flushing, dry as a bone for dry mucous membranes, blind as a bat for dilated pupils, and mad as a hatter for altered mental status, hot as a hare for a fever. Other central nervous system symptoms can include seizures, delirium, and significant agitation. An important cardiac consideration: Benadryl overdose can be associated with wide complex tachycardias and QT prolongation, so cardiac monitoring is essential. Our treatment is largely supportive. Manage agitation and seizures with benzodiazepines, provide IV fluids for hemodynamic support, and implement cooling measures if hyperthermia is present. Early recognition, supportive care, and close monitoring are the keys to managing anticholinergic toxicity effectively. Lastly, I have cyanide poisoning. Cyanide can be found in numerous environments. It may be present in certain foods, in manufacturing and industrial settings, and most commonly from the combustion of synthetic materials. In fact, structure fires are one of the most common sources of cyanide exposure in the pre-hospital setting. Cyanide works by inhibiting aerobic metabolism. Specifically, it interferes with the ability of cells to use oxygen to create ATP. Even though oxygen may be present in the bloodstream, the cells are unable to utilize it. This creates a state of cellular hypoxia. Cyanide also interferes with oxygen binding at the cellular level, further worsening tissue hypoxia. The end result is decreased energy production and severe metabolic acidosis. Routes of exposure matter. IV and inhalation exposures have a much more rapid onset. Cyanide can also be absorbed through the skin, which is especially concerning in industrial or fire-related exposures. One important medication related to remember is sodium nitroprusside. This IV medication contains cyanide and can lead to toxicity, especially with prolonged or high-dose rapid recognition of cyanide toxicity. Rapid recognition of cyanide toxicity is critical because deterioration can occur quickly, particularly in inhalation exposures. Early signs and symptoms include headaches, dizziness, confusion, dilated pupils, and altered mental status. As cellular hypoxia worsens, patients may develop hypoxia, seizures, and eventually coma. You'll often see tachypnea and tachycardia early as the body attempts to compensate for impaired oxygen utilization. As toxicity progresses into later stages, hypotension and bradycardia may develop. One classic but not always present finding is cherry red skin. This occurs because oxygen remains in the bloodstream since the cells are unable to use it effectively. Treatment begins with aggressive support of the ABCs, secure the airway, provide high flow oxygen, and assist ventilation as needed. Remove the patient from the source of exposure and remove contaminated clothing to prevent further absorption. The antidote for cyanide poisoning is hydroxycobalamin. It binds cyanide and allows it to be safely excreted. Hydroxycobalamin is especially useful in cases where carbon monoxide exposure may also be present, such as in structure fires. Early recognition, rapid supportive care, and prompt antidote administration are critical to improving survival in cyanide toxicity. So if we take a closer look at hydroxycobalamin, we see that it's a manufactured form of vitamin B12. It serves as a precursor to two active forms of vitamin B12 that are involved in DNA synthesis, amino acid metabolism, fatty acid metabolism, and maintenance of normal nerve function. In the setting of cyanide poisoning, its mechanism of action is straightforward and effective. Hydroxycobalamin binds to cyanide molecules and detoxifies them before cyanide can inhibit cellular metabolism. Once it binds to cyanide, it forms cyanocobalamin. This compound is then safely excreted in the urine. The recommended dose is 70 milligrams per kilogram with a maximum dose of 5,000 milligrams. One important advantage of hydroxycobalamin is that it has no IV contraindications, making it relatively safe and reliable antidote in suspected cyanide exposure. Before we officially close out this lesson, I want to give you some clear direction on what to review. Take time to go back over your drug cards and make sure you are solid on the medications we discussed today. That includes benzodiazepines, Haldol, droperidol, ketamine, glucagon, atropine, Tupam, and hydroxycobalamin. Don't just memorize the doses. Understand the mechanism of action, indications, contraindications, and major adverse effects. If you can explain how the drug works, you'll be far more confident using it in the field. I also want you to review the applicable EMS state protocols. Specifically, go through carbon monoxide and cyanide protocol, TE2, the nerve agent protocol, TE8 and 9, our behavioral protocols, UP18 and 19, and lastly, our overdose and toxic ingestion protocol, TE7. As you review, think in patterns. What are the toxidromes? What are the red flag vital signs? What are the airway considerations? And where do these medications plug into the protocol decision tree? Your goal is not just to pass your exams. Your goal is to be able to recognize these presentations quickly and act decisively in a real and simulated patient encounter. So go back through the protocols, work through your drug cards, and make sure you can connect mechanism to presentation and presentation to treatment.